issue in Canadian healthcare: hospital-acquired infections, specifically catheter-associated urinary tract infections. Over the past 2 years, counties have become significant quality and safety concerns due to increasing antimicrobial resistance, lapses in infection control, and the pressures of high patient volumes. These infections result in higher rates of morbidity, mortality, and healthcare costs, emphasizing the urgency of addressing this challenge. As a nurse leaders, it is essential to strengthen infection control protocols, promote antimicrobial stewardship, enhance surveillance and reporting, foster a culture of safety, leverage technology, and collaborate with stakeholders to implement effective solutions and improve patient outcomes. Solutions to cavities. First is practice proper hand hygiene, ensuring thorough hand washing or using hand sanitizers before and after handling urinary catheters can significantly reduce infection risks. Second is avoiding unnecessary urinary catheters. Carefully evaluate and document the need for catheterization. Consider alternatives and regularly review the necessity to minimize the risk of cavities.
Insert urinary catheter using aseptic technique. Utilize sterile equipment and aseptic procedures during catheter insertion to maintain a sterile environment and reduce infection risk. Catheters based on best practice guidelines. Follow established protocols for the care and maintenance of urinary catheters, including regular cleaning and timely replacements. Adhere to policies and procedures. Ensure compliance with institutional policies and procedures that promote safe and effective catheter use and maintenance, including evidence-based protocols for bladder scanning and catheter removal. And competent healthcare workers. Only healthcare workers with proper training and demonstrated competency in aseptic techniques should perform catheter insertions. Enhanced practices such as having 2 RNs present, one to perform insertion and the other one to observe and ensure sterile technique, can be beneficial.
To continue the solution to cavities, another is utilize checklists for routine maintenance. Implement checklists to standardize the routine care and maintenance of urinary catheter. This ensures all necessary steps are consistently followed with ongoing monitoring and staff education to ensure compliance with best practices and CDC guidelines. Next is conduct outcome surveillance for cavities. Monitor and track the incidence of healthcare-acquired UTIs and cavities, and evaluate compliance with catheter care bundles to identify areas for improvement and enhance patient safety. For interventions in 2014, Foley devices utilization in the ICU or IMCU was at 57% following improvements. By the end of 2015, utilization decreased to 48%, reflecting a 9% absolute decrease and a 15.78% relative change. Over 2014 to 2016 period, Foley devices utilization decreased by 17% in absolute terms, with a relative reduction of 29.18%. In 2014, there were 8 cavities in the ICU. In both 2015 and 2016, only 1 cavity occurred each year, and a zero cavity rate was maintained for 394 consecutive days from May 2015 to May 2016.
Addressing barriers and overcoming challenges. Lack of awareness and training. Implement comprehensive training program for all ICU staff, emphasizing the importance of cavity prevention and proper catheter management techniques. Utilize workshops, online modules, and hands-on demonstration. Resistance to change. Apply Kurt Lewin's unfreezing, change, rephrasing model. Start by communicating the need for change, which is unfreezing. Inconsistent protocol adherence. Develop clear, easy to follow protocols and checklists for catheter insertion and maintenance. Conduct regular audits and provide immediate feedback to ensure adherence. Recognize and reward consistent compliance to all employees.
Resource constraints. Ensure adequate staffing and resources for catheter care, such as having 2 RNs present during insertion. Advocate for necessary supplies and support from hospital administration. Communication gaps. Foster open communication channels among the multidisciplinary team. Communication gaps. Foster open communication channels among the multidisciplinary team. Hold regular meetings to discuss progress, address concerns, and share best practices.
Implementation and testing using the PDSA cycle. First is plan. Under plan, define the objective. Reduce CAUTI rates by 30% within 6 months. Second is assemble a multidisciplinary team like ICU nurses, infection control specialists, physicians, and administrators. Third is develop and refine protocols based on CDC guidelines. And lastly, plan training sessions and educational materials.
First, implement the new protocols and training programs. Second, start with a pilot phase in one ICU before scaling up to other units.
The third is study. First is monitor CAUTI's rates and protocols compliance during the pilot phase. Second is collect and analyze both qualitative and quantitative data. The third is hold regular team meetings to review progress and identify areas for improvement.
Act. Adjust protocols and training based on feedback and data analysis. Scale up successful practices to all ICUs. And continuously monitor CAUTI rates and compliance, making further adjustment as needed. By addressing these challenges with evidence-based strategies, we can significantly reduce CAUTI rates and improve patient outcomes.
Thank you for watching!
And let's work together to enhance the quality and safety of our healthcare system. Bye!